Welcome, everyone. So here we go. And I'll try to make it as quick as I can. But as always, feel free to unmute. Feel free to ask questions. Do whatever you want to do. Interrupt me on the slide that we're on. However you want to do this is fine with me. I love interaction. So do not be shy. Ask all the questions because if you have a question and you're not understanding something, I promise you other people on this call have the same questions. So feel free to ask. Here we go. Pac-Man, Medicare Part D prescription drug coverage. And of course, we have our beautiful Atari. We are just going to jump right in on the Part D prescription drug plan changes for 2026. As part of the Inflation Reduction Act, you'll be hearing it called IRA. I always call it the Inflation Reduction Act because an IRA to me is another mechanism that we use for retirees or people planning retirement. So the Inflation Reduction Act, Congress made several changes to the Part D program, including the elimination of the coverage gap. I will forever call the coverage gap a donut hole, and capping out-of-pocket costs. The Inflation Reduction Act changes that will be implemented for the first time in 2026 include negotiated prices will apply to certain drugs. The Inflation Reduction Act provided Medicare the ability to directly negotiate the prices of certain high expensive single source drugs without generic or biosimilar competition. CMS selected 10 drugs covered under Medicare Part D for the first cycle of negotiations for initial price and applicability. I cannot say that word. Year for 2026. My accent gets in the way of a lot of these words. During the initial coverage phase, CMS will pay Part D plans a subsidy of 10% of drugs selected for the price negotiations during the price while applicability period. During the catastrophic phase, CMS will pay Part D plans 40% reinsurance for those drugs selected. CMS subsidy and reassurance. The CMS subsidy and reassurance changes do not impact beneficiary cost sharing percentages, which were substantially reduced beginning in the plan year of 2025 by eliminating the donut hole coverage gap and capping the out-of-pocket costs. However, they will affect the price of the negotiated drugs. To be eligible for Part D, individuals must be entitled to Part A and or enrolled in Part B. So contrary to Medicare Advantage and Medicare Supplement plans, to be in a standalone PDP, you do not have to be enrolled in Part B. You do not have to have A and B, just simply entitled to A or enrolled in Part B. And a U.S. citizen or lawfully present in the United States on or before the enrollment effective date. PDPs must enroll any eligible beneficiary who applies, regardless of health. To attain Part D benefits from other types of Medicare health plans, such as MAPD, Medicare cost plans, or PACE, the individual will have to meet additional eligibility criteria for those plans. For example, to enroll in an MAPD, you must have both A and B. Medicare Part D prescription drug eligibility. Again, generally only beneficiaries enrolled in a Medicare, original Medicare, MSA, PFFS plans, or a cost plan may enroll in a standalone PDP to receive Part D benefits. Beneficiaries enrolled in an MSA may only get Part D benefits through a standalone PDP. I'm going to repeat that because you're going to see that one. Beneficiaries enrolled in a MSA may only get Part D through a standalone PDP drug plan. Beneficiaries enrolled in a cost plan or MAPFFS plan may obtain Part D benefits through their plan if offered or through a standalone PDP. Beneficiaries enrolled in an MAHMO or PPO may only obtain Part D benefits through their plan. Employer group plan enrollees may have additional options. And if you remember from the past few days, employer groups plans have different rules than the traditional Medicare plans. Individuals enrolled in a PACE plan may only receive their Part D benefits through their plan. Part D basics. The Part D covers certain prescription drugs, diabetic supplies, and vaccines. Part D benefits are provided only through private companies. There is no fee for service Part D benefit. The types of Medicare plans that include Part D benefits are standalone prescription drugs and Medicare Advantage prescription drug plan. Cost PEDs are Medicare cost plans that cover Part D prescription drugs as an optional supplemental benefit. And of course, the PACE plans. Part D covers prescription drugs, biologics. If anybody doesn't know what a biologic is, they are drugs made from natural sources, human, animal, or microorganisms that are not chemically synthesized. Examples include allergy shots and gene therapies. Insulin, medical supplies associated with the injection of insulin, such as syringes, needles, alcohol swabs, and gauze, or delivering insulin into the body. An inhalation chamber, which I don't know why that would be for insulin, are also covered. And vaccines not covered by Part B, for example, shingles, RSV, and the whooping cough vaccines. The drugs that are excluded from Part D are drugs for weight loss or gain, fertility, cosmetic purposes, symptomatic relief of cough and colds, vitamins, prescription vitamins, and minerals, with the exception of prenatal vitamins and vitamins D2 and D3 are excluded from Part D coverage. Medical foods consumed or administered internally under the supervision of a physician that are not regulated as drugs under Section 505 of the Federal Food, Drug, and Cosmetic Act. Erectile dysfunction drugs when used for sexual dysfunction. And something I learned about that, I say this every year because I had the biggest, most embarrassing story ever. Somebody needed a on their drug search, it had Viagra, and much to my surprise, that was originated for heart medication and is still used as a heart medication as well. So not everything that has that label is used for sexual dysfunction. It may be for use for the prostate wellness or for the heart. Non-prescription drugs are excluded from Part D. Some off-label use of drugs. There's a lot of off-label use, and sometimes they are denied for that purpose. So even if you show it on formulary and somebody says, hey, the plan's not going to cover it, I guarantee you it's for off-label use, and the doctor is going to have to ask an exception from the plan. Drugs covered under Part A and B. Part D plans can offer supplemental benefits that cover drugs that otherwise meet the definition of a Part D prescription drug but are explicitly excluded from coverage, such as certain prescribed weight loss drugs. The biggest off-label use that we see, and everybody on this call knows it, is going to be the Ozempic type drugs that are not used for controlling diabetes. Whenever you are talking to everybody and you're getting their drug use or their drug list, and they mention one of those, I always ask if they are diabetic because there are plans might be available in their area, especially tailored for those who have diabetes. That is an easy way for me to make sure that it's not being used for weight loss on the Mounjaro and stuff like that. Formularies. Part D plans typically do not include all available drugs in each category of covered drugs, as several similar medications may exist to treat the same medical condition. Part D plans include the Part D drugs they will cover on a list known as formulary. Formularies are developed by pharmacists, doctors, and other experts. How many times have we heard somebody say, why do insurance companies get to make all the decisions whenever my doctor has requested this? The simple answer is that pharmacists and doctors are on that list of panels who also look over what drugs will be covered under the plan. Part D plan formularies must include at least 2 drugs in each therapeutic category, generic and name brands, and there's an all protected class of drugs. There are 6 protected drug classes. There are 6 classes, which are categories of drugs that treat life-changing or life-sustaining conditions, such as antidepressants, antipsychotics, and anticonvulsants, immunosuppressants. They're listed. I can't say all those words. All Part D covered drugs selected for Medicare price negotiations will have the negotiated maximum fair price in effect for the specified period. Part D plan may remove the drug if certain requirements are met, including replacing it with a generic version of a brand name drug that was not available on the market when the plan submitted its formulary. We all know that if the generic doesn't work for the beneficiary, that their doctor can ask for an exception and get the name brand covered. That's how you combat that when they call you if you have an issue arise. Drug tiers. Tiered costs means grouping a Part D drugs into different cost sharing levels with a Part D formulary. Many plans group drugs into 3 or 4 tiers, even more, 6, up to 6, with lower tiers requiring less beneficiary cost sharing than higher tiers. For example, Tier 1 is generic, Tier 2 is preferred brand name, Tier 3 is non-preferred brand name, and Tier 4 is high-cost drugs or specialty drugs. We know that many plans offer more tiers than that, including a Tier 6. So this is, you want to confirm beneficiary drugs are on formulary and evaluate the cost share, especially when we get into those higher cost tiers, into the specialty drug categories. D, benefit structure. All Part D plans must cover at least the Part D standard benefit or meet the requirement for alternative benefit. Benefit structures that are not standard but instead are actuarially equivalent are known as alternative coverage. The standard benefit structure includes several coverage phases, such as a deductible initial coverage phase and the catastrophic coverage phase that applies after the beneficiary reaches the annual out-of-pocket max. For 2025, if we all remember, it is $2,000. The alternative coverage. Actuarial equivalent means that the value of the Part D benefits must be at least as the same as standard coverage. Alternative coverage must also not have an annual deductible that exceeds the annual deductible under the standard benefit imposed cost sharing once the annual out-of-pocket limit is met. Alternative benefits may also be structured with some or all of the coverage phases that are part of the standard benefit. Some Part D plans may offer enhanced coverage for an additional monthly premium known as enhanced alternative benefits. Coverage enhancements may include a reduction of the deductible, including waiving the deductible for a set of formulary tiers. We see that a lot. We see that there is a $590 deductible on some plans, excluding tiers 1 and 2, meaning that they do not have to meet the deductible before they can experience the cost share for those drugs. And typically, Tier 1 and 2 for a 90-day extended supply on maintenance medications are 0, typically. Coverage of excluded drugs or decreased coinsurance amounts in the initial coverage phase. Standard Part D benefits 2026. For 2026, the standard benefit requires the beneficiary to pay a $615 deductible, 25% of prescription drug costs during the initial coverage phase. Once the out-of-pocket costs reaches $2,100, so it went up from $2,000, the beneficiary reaches the catastrophic coverage. The out-of-pocket costs that count toward reaching the catastrophic limit are known as true out-of-pocket costs or TROOP, and we'll dive into TROOP, don't worry. In some instances, amounts not directly paid by the beneficiary count toward TROOP. After reaching the annual out-of-pocket threshold, the beneficiary pays nothing. Any questions? Okay, moving forward. Insulin and vaccines. There is no cost sharing for Part D vaccines recommended by the Advisory Committee on Immunization Practices, ACIP. That is on the test, by in-network or out-of-network providers, even in the deductible phase. This includes vaccines for shingles, Tdap, and RSV. The cost sharing for 1 month supply of a covered insulin product cannot exceed $35 in any coverage phase. Let's repeat that. The cost sharing for a 1 month supply of a covered insulin product cannot exceed $35 in any coverage phase. It doesn't matter if it's the deductible phase, and it does not matter if it's where it's at. It is going to be $35 for the covered insulin. CMS plan to manufacture payments for drugs. Initial coverage phase. Part D plans typically pay 65% for applicable drugs and drugs selected for negotiation. Plans pay 75% of all other Part D covered drugs. The manufacturer's discount program pays 10% of the cost of applicable drugs. CMS pays a subsidy of 10% of a drug's negotiated price for the selected drugs during the period when the negotiated price applies. They never really dive into that. So I'm sure there's going to be a lot more coming out as we look at plan designs for 2026. But for now, to get through AHIP, this is the information you need to know. Catastrophic coverage phase. Part D plans pay 60% of the cost of all Part D covered drugs. The manufacturer's discount program pays 20% of the cost of applicable drugs, and CMS pays a reinsurance subsidy of 20% for applicable drugs and 40% for all other Part D drugs during a price applicability period. Why? True out-of-pocket costs. Refer to expenses that contribute to the annual out-of-pocket limit required to enter the catastrophic phase. TROOP is calculated on an annual basis. TROOP includes beneficiary payments for Part D prescription drugs, including the annual deductible and cost sharing above the deductible up to the annual out-of-pocket threshold. For the drug cost to count towards TROOP, this is on the test, drugs must be on the plan's formulary and be purchased at the plan's participating network pharmacy. So again, for the drug cost to count towards TROOP, drugs must be on the plan's formulary and be purchased at the plan's participating network pharmacy. Amounts paid by the AIDS Drug Assistance Program and the Indian Health Services also count towards TROOP. Amounts paid by or through qualified state pharmaceutical assistant programs known as SPAPs. Most charities, health savings accounts, flexible spending accounts, and medical savings account also count towards TROOP. Supplemental Part D coverage provided by enhanced alternative Part D plans and other health insurance. This includes supplemental coverage provided by employer group waiver plans, as well as Medicare plan reductions and cost sharing for enrolled beneficiaries, such as reductions by DSNPs. Medicare Prescription Payment Plan, M3P, participates with TROOP eligible costs that are paid by their Part D. So what that is saying, we may go into this here in just a minute. I can't remember. I made this over a week ago, but the Medicare Prescription Payment Plan, the M3P plan, is going to stay in force. Beneficiaries are going to be able to use it, but it's only going to be useful for those drugs who are on the formulary of the plan. They will not be able to be billed for plans off formulary. Costs do not count towards TROOP. Costs for drugs not on a Part D plan's formulary. I guess I could have waited for my little explanation. Unless the beneficiary receives a formulary exception under which the plan covers the drug. Costs for over-the-counter and other non-Part D drugs do not count towards TROOP. Costs for Part D drugs obtained out-of-network, unless there's an out-of-network coverage policy that applies. Costs paid for or reimbursed to an enrollee by insurance, a group health plan, most government-funded health programs, or any other third party. Medicaid, state children's health insurance, CHIP, federally qualified health centers, rural health clinics, you can see it all right there. It does not count towards TROOP, including the Black Lung funds. Costs for drugs purchased outside the United States, so those who have members or clients that shop in the Canadian pharmacies, those will never count towards TROOP. And the manufacturer payments made under the manufacturer discount program also does not count towards TROOP. Part D coverage is provided through contracted network pharmacies in the plan service area, PFS plans are not required to use a pharmacy network, but may choose to. That is all over many modules in the AHIP and also on the final exam. Network pharmacies include retail pharmacies, long-term care pharmacies, and may also include mail order pharmacies. Part D plans may designate some pharmacies as preferred that offer lower levels of cost sharing than apply at other network standard pharmacies. I see, I work when complaints come in, I work those, and believe it or not, there are complaints that's come in, and this also happened when I worked at the carrier. This is just a common thing that happens, and I want to draw attention to it because it's so preventable. If somebody is on a plan that utilizes CVS as their preferred network, and Walgreens is not the preferred network, it is a standard pharmacy, the cost is going to be more at the Walgreens versus the CVS. So just anytime you see that you see it's a standard, that the cost sharing is going to be at the standard pharmacy, make sure you tell them that, and also tell them who the preferred pharmacy is. Whether you use Sunfire or what have you, it will indicate where a preferred pharmacy, if there is one. Beneficiaries are required to fill prescriptions for covered drugs at network pharmacies. Under certain circumstances, enrollees may fill prescriptions for covered drugs at an out-of-network pharmacy at a higher cost to enrollees. I know we have to know that, but if you all have noticed, most people can go to a national chain that is a network with their plan and get the cost sharing that they're used to. That's just my free tidbit of information. Part D plans may charge a premium. I have noticed more and more Part D plans are charging premium versus not. Typically, a higher premium means lower out-of-pocket costs for the plan. Part D enrollees have 3 options for paying their premium. It can have an automatic electronic monthly mechanism, such as withdrawal from checking or savings account, or automatic charge against their credit or debit card, direct monthly billing from the plan, and automatic deduction from Social Security or their railroad retirement checks. Typically, it takes 2 to 3 months for Social Security withholding to begin or end. When the withholding begins, it will be for the 2 to 3 months of premiums owed. So what that is saying is, if somebody signs up for an effective date of January 1st, they may not see the withholding for their Part D until February or March, and when they do, it will be for the months that they owe in the arrears. Generally, the beneficiary must stay with the premium payment option they chose for the entire year. I believe the exact question that we see every year on AHIP is, so-and-so has a small savings account and would like to use that until it's exhausted. What should you recommend? And the answer is they should use the same premium payment option they chose for the entire year. You will see that. If an enrollee does not choose an option, the beneficiary will be billed by the Part D plan monthly. It will not automatically go to Social Security withholding. The late enrollment penalty. I don't know about you all, but I just love it when there's an LEP. Sarcasm. Non-Medicare insurers are required to notify beneficiaries annually whether or not the prescription drug coverage they have is creditable. Coverage that expects to pay, on average, at least as much as Medicare's standard Part D coverage. Beneficiaries may have to pay a monthly premium penalty to join a Part D plan if they do not have credible drug coverage and do not enroll when first eligible for Part D. If they have 63 continuous days or more following the initial enrollment period for Part D, during which the beneficiary did not have either Part D or other credible drug coverage, the penalty will be 1% of the national average beneficiary premium for each month the beneficiary did not have Part D or credible coverage. The penalty is in effect for as long as the beneficiary has that Part D coverage or any Part D or Medicare prescription drug coverage. So if they want to change plans to avoid the penalty, no such luck. Medicare is going to notify all carriers that this person has a late enrollment penalty. Beneficiaries who qualify for the low income subsidy are not subject to the late enrollment penalty. Drug management tools, in addition to formularies and cost sharing tiers, Part D plans use a variety of drug benefit management tools, including step therapy, prior authorization, quantity limits. You're really going to see the quantity limits when it comes to the narcotics. It's for safety and cost reasons. Part D plans limit the amount of certain prescription drugs they cover for a specific period. 9 times out of 10, that's going to be an opioid or a narcotic. Substitution. Part D sponsors may substitute generic drugs for brand name drugs if the generic drugs have the same or lower cost sharing and certain conditions are met. Comprehensive Addiction and Recovery Act, CARA. Plans may impose certain limitations on prescribers or pharmacies for a beneficiary can use and manage utilization for beneficiaries who are at risk of misusing or abusing frequently abused drugs such as opioids. Step therapy, going back to that, requires enrollees to try one or more of the lower cost drugs before other more expensive drugs are covered. If they've already done that and they're telling you that they've already tried the generic drugs, once they get enrolled into the plan, their doctor can say, we've exhausted the generics and only this name brand drug works. And at that point, they will not require that any further. Prior authorization requires the doctor to contact the plan and request authorization before the plan will cover a prescription drug. The doctor must show the plan that the drug is medically necessary for it to be covered. Part D transition requirements. Part D sponsors must provide coverage of a one-time temporary supply of non-formulary drugs or Part D drugs that are on a sponsor's formulary but require a prior authorization, step therapy, or are subject to quantity limit that is not safety-based to the following individuals taking such a drug: beneficiaries initially enrolling in Part D, beneficiaries switching plans, and current enrollees affected by certain formulary changes other than allowable substitutes of a generic drug for a brand name drug. This coverage is known as a transition refill. That gives members times, especially those who are turning 65 or if they are on a plan or move to a plan and they had a drug that was covered before and maybe it needs a prior authorization or whatever happens, it gives it time that it may be on the formulary but wouldn't be automatically approved. It gives the doctor time to get that arranged with the patient into the plan. Part D transition requirements. Beneficiaries are eligible for transition refills must receive a coverage of at least a 1-month fill of their non-formulary drugs during the first 90 days after enrollment, the plan switch, or formulary change. Transition refills are only for drugs that the beneficiary was already taking. This isn't going to be something that they decided to start taking. This is only for medications they are already using. They do not apply to new prescriptions. During the transition period, the Part D plan does not apply to prior auth, non-safety-based quantity limits, step therapy rules. The enrollee and their physician can request an exception to the Part D plan's formulary to continue coverage of the non-formulary drug or can transition to a formulary drug that is covered. A lot of times you'll see that with Humalog and Novolog. They're exactly the same medication, but some plans cover Humalog and other plans cover Novolog. It's an insulin. The Medicare Prescription Payment Plan, M3P. Part D sponsors are required to provide all Part D enrollees the option to pay their cost-sharing amounts, including any deductibles, copayments, or coinsurance, and monthly amounts spread out over the plan year, instead of paying them in full at the point of service. Part D enrollees can opt into the Medicare M3P program at the beginning of the year or at any point during the year. Part D enrollees who choose to participate in the program pay nothing at the point of service for a Part D covered drug, but are billed each month by the plan. Monthly payments do not start until the beneficiary opts into the program and first incurs out-of-pocket costs for the covered Part D drugs. The amount that the Part D sponsor bills the enrollee for a month under the program cannot exceed maximum monthly cap, calculated based on each enrollee's cost and the point in the plan year in which the enrollee is enrolled in the program. The monthly cap varies from month to month. Opting in the program will not impact how a Part D enrollee moves through the phases, such as deductible, initial, into catastrophic, or what counts towards their true out-of-pocket costs. It'll all be accumulating towards their troop and their max out-of-pocket. They will just have an easier time paying, especially those who have expensive drugs that they plan to max out of the Part D plan in the year. It just makes it easier to pay each month. Who benefits from the M3P program? Those incurring high out-of-pocket costs earlier in the plan year are generally more likely to benefit. So those who have a deductible phase and have some of those specialty tiers, they would 100% benefit from the M3P program. Part D enrollees with low to moderate recurring out-of-pocket drug costs, such as maintenance medications, are not likely to benefit from this program because their costs are already distributed evenly throughout the year. And if you look at the formularies, I don't know about you all, but when I'm quoting, most of the maintenance drugs are affordable, especially if they're tier 1 and tier 2. It's when you get into tier 3 that it's a balance for some of them, especially with like Eliquis and stuff like that. That's those are the people that I would definitely encourage to get on the M3P program. Enrollees can opt out of the program at any time. However, they will continue to be billed monthly for any cost sharing amounts that they still owe. Failure to pay the monthly billed amount will result in disenrollment from the program, not the plan. It's very important that they know that, because if they get a letter because they missed a payment on the M3P program, they may be in a panic, feeling like they've lost their Part D. They have not. They can just no longer participate in the M3P program. After a specified grace period, there is a grace period that is listed in each plan. However, the Part D sponsor will continue to bill amounts owed under the program in monthly amounts. The sponsor may also offer the beneficiary the option to repay the full outstanding amount in one lump sum. Once the beneficiary leaves the program, they must resume paying their out-of-pocket costs, sharing at the point of service at the pharmacy. Members' rights, Part D. This is very similar to what we had yesterday when we were talking about rights that beneficiaries have under MAPD. But today we're going to talk about Part D. Requesting coverage determinations and appealing decisions. Members have the right to request a determination of whether a plan will cover a drug, and that's known as a coverage determination, and appeal adverse coverage decisions, including decisions tiering or formulary exception requests. So if the tier, there's an exception granted and the tier is outrageous, maybe it's a specialty tier where they're paying co-insurance instead of a copay, they have the right to request that down to a lower tier. Not saying it'll happen, but they can request it. Part D plan sponsors must provide access via a secure website or secure email address on the website for enrollees to quickly request a coverage determination or appeal a coverage decision. Plan sponsors must also require network pharmacists to provide enrollees with a printed notice with the plan's toll-free number and website for requesting a coverage determination. Requesting exceptions for drugs. Enrollees have the right to request coverage of a drug that is not on a Part D plan's formulary or request exceptions from the plan rules, such as prior authorization, step therapy, quantity limits. Such requests are known as formulary exception requests. Enrollees also have a right to request coverage of a formulary drugs at a less costly formulary tier. This is known as a tiering exception. Exception requests must be accompanied by a supporting statement from a physician or other prescriber explaining why the exception is necessary. So if somebody calls you and says, I do not like paying $300, which is my cost share with this expensive tier 5 for drug, I would rather it be a tier 3, the doctor will have to write in and say why it's necessary for this request. You, the agent, and not even the member can call in and request that. It will have to be done through the provider. A standard form is provided on Part D plan websites for enrollees to request a coverage determination, including formulary tiering exception. A physician or other prescriber may also request a tiering or formulary exception. But it is always going to be accompanied by a physician, so it's just best to advise that they go to their doctor and have them request an exception through the plan. Filing grievances, Part D. Beneficiaries may also file complaints about their Part D plan or their pharmacies. These complaints are known as grievances. Grievances include complaints about issues such as pharmacy wait times, plan's failure to mail a beneficiary requested material, or the length of hold time on the plan's customer service line. Grievances do not include complaints about a Part D sponsor's refusal to cover a drug or approve an exception request. Beneficiaries must resolve such issues through the appeals process. That is on the test. So take a picture of the slide. Limited income. Beneficiaries with limited income and resources should be encouraged to apply for low-income subsidy, also called extra help, we call it LIS, through the state Medicaid office or the Social Security Administration. I have walked many members or clients through this, and it's a very simple form on the ssa.gov website. It's super easy to navigate, and I always strongly suggest that you utilize the website versus calling. It's insane. Beneficiaries must apply may apply at any time. If beneficiaries apply at the state Medicaid office for Part D help, the state Medicaid office will also check for eligibility for other low-income assistance programs, such as food benefits, Medicaid, other things. They may also call SSA at 1-800-772-1213 or apply online. After SSA or the state approves the application for extra help, it is effective on the first day of the month in which the individual applied. So if it is the 15th of July, it will retro back to July 1st for the LIS. Here's a trick question for anybody who may or may not want to answer it. I'll answer it if nobody does. But what does LIS also help with that's related to maybe Part B? It can also help with the late enrollment penalty of Part D and B, and it also can offset some of that as well for the premium. Those who automatically qualify for extra help, they have full Medicaid coverage. They get help from their state Medicaid program paying for their Part B premiums in a Medicare savings program. They get supplemental security income known as SSI benefits. Medicare mails these individuals a purple letter to let them know they automatically qualify. They should keep this letter for their records. They do not need to apply for extra help if they receive the purple letter. Help for those with limited income and limited resources. If a beneficiary has limited income and resources, they may qualify for LIS to cover all or part of the premium and cost sharing. To qualify for LIS in 2025, the income may not exceed 150% of the FPL, which is federal poverty level. The 150% FPL varies geographically. In addition, beneficiary resources may not exceed the published limit. The resources counted toward the limit include bank accounts, stocks, bonds, and other liquid resources that beneficiaries can readily convert into cash within 20 days, and real estate that is not the beneficiary's primary residence. CMS publishes the resource limits for each year in the late fall of the previous year. For 2025, beneficiaries' resources may not exceed $16,100 or $32,130 if they are a couple. These limits are increased by $1,500 per person if the beneficiary notifies the Social Security Administration that they expect to use some of their resources for burial expenses. Based on the 2025 FPL's income limits are as follows. 48 states in DC is $23,475, $31,725 for a couple. Alaska was $29,000, $39,000 for a couple and some change. And Hawaii was $26,985 or $36,480 for a couple. Just FYI, that's not on the test. 2026. For 2026 individuals who qualify for full LIS and are full benefit dual eligibles, FBDEs. We talked about the different levels of dual eligibles yesterday. If you were not able to attend, we're happy to share that with you. With income at or below 100% of the federal poverty level and resources below the applicable threshold have a $0 deductible and cost sharing of $1.60 for generic and $4.90 for all other drugs. For 2026, individuals who qualify for full LIS and are FBDEs with income over 100% of FPL resources below applicable threshold have a $0 deductible and $5.10 for generic drugs, $12.65 for all others. For 2026, those who qualify for LIS but are not FBDEs, they have a $5.10 for generic and $12.65 for all other drugs. And I'll leave this up for a second so everybody can get a picture so that you have that information available to you in case somebody has a question. All right, any questions? Okay. Pharmaceutical assistance programs. Some pharmaceutical manufacturers have programs that assist individuals in obtaining drugs at a reduced or no cost. Some states have assistance programs designed specifically for their residents. Some programs are qualified state pharmaceutical assistant programs or SPAPs that count towards TROOP, and some do not count towards TROOP. Becoming familiar with the states that you sell in programs may allow you to help a beneficiary address cost sharing on their prescriptions. How many of you have ever heard of LINet program? I was wondering this when I was creating this. Anybody?
I don't think I've ever heard of it.
I hadn't either. Let's dive into it. The LINet program provides temporary medical Part D coverage to people with low income and Medicare who are not already enrolled in a Medicare drug plan. So you got your full benefit dual eligible SSI only beneficiaries on a retroactive basis up to 36 months in the past. LIS eligible beneficiaries at the pharmacy counter and up to 30 days in the past. If a beneficiary paid for prescription drugs out of pocket before they join a Medicare drug plan, but after they qualified for both Medicare and Medicaid or Social Security income due to disability, they may be able to get paid back for those costs. And that's where this up to 36 months in the past comes in. LINet application form can be found at cms.gov/Medicare/enrollments low income subsidy. I'm sure they have a big icon that directs you on the Medicare or on the cms.gov website. Employer, union, and other coverage drugs. Employers and unions will notify their employees of whether their non-Medicare prescription drug coverage is credible. If coverage is credible and the beneficiary keeps it, the beneficiary will not have a premium penalty if later they lose or drop the employer coverage and join a Part D plan within 63 days. That's 63 days, guys. Just remember, Part D, 63 days from losing coverage because it is on the test multiple times. If coverage is not credible, the beneficiary will need to enroll in Medicare Part D during their initial eligibility period to avoid the late enrollment penalty, LEP. If a beneficiary has credible drug coverage through TRICARE, the VA, or FEHB, they can compare that coverage with available Part D plans to decide whether to enroll in a Part D plan. There will be no late enrollment penalty if the beneficiary retires or otherwise loses employer union credible coverage and joins a Part D plan, or gains credible coverage within 63 days. Medicaid drug coverage. When a Medicaid beneficiary becomes eligible for Medicare, Medicare instead of Medicaid covers the Part D drugs once the beneficiary is enrolled in a Part D plan. If Medicaid beneficiaries do not choose the plan, Medicare will select one for them. And that's just for a thing of beauty. Wow, we did that fast, guys. I can't believe we got through 50 slides that quick. So again, I am Taryn Mott. I am the Director of Provider Referral Operations and Agent Training, and Charlie is the Manager of Provider Referral Operations and Agent Training. If ever you have questions, we're always available. Whether you work for us or not, we're happy to help. It's just what we've always done, and we've always been together, and we love helping. Thank you guys for attending, and email me if you would like a copy of my PowerPoint. Talk to you all soon. Thanks.